I am Namrata Pal of Jims Medical College, third year MBBS student, going to start a series on lectures of ophthalmology. Now, let us divide the diseases of eye. First is on the basis of anatomy. It can be disease of conjunctiva, disease of cornea, disease of sclera, disease of uveal tract, diseases of lens, mainly cataract, diseases of vitreous humor, diseases of retina, diseases of eyelid, diseases of lacrimal apparatus, or diseases of orbit. Now, if we mention the functional basis, then it can be error of refraction and accommodation, glaucoma, disorders of ocular motility, and diseases can also be classified on neurological basis or traumatic basis. Now, today we will focus mainly on conjunctiva. Depending upon the diseases of conjunctiva, there are total 4 categories. One is inflammation. Inflammation of conjunctiva is known as conjunctivitis. Now, degenerative condition of the conjunctiva, it can be pinguicula, pterygium, concretions, amyloid degeneration. Now, symptomatic conditions like hyperemia, chemosis, ecchymosis, and discoloration. Now, lastly, cyst and tumors. Today, our main focus will be conjunctivitis. Now, depending upon the etiology, conjunctivitis can be infective, allergic, cicatricial, or toxic. Now, again, infective conjunctivitis can be divided into bacterial infective conjunctivitis, viral infective conjunctivitis, chlamydial infective conjunctivitis, or granulomatous infective conjunctivitis. Now, in recent time, questions are case based. Some symptoms or clinical findings or investigatory findings are given in the question, and we are asked to find out the diagnosis, then write about that. Directly, the category of disease, like which type of conjunctivitis is mentioned in the question, is not known to us. So, to find that, we have to know the comparative study of the clinical feature and cytological features of the types of conjunctivitis. So, for this reason, I have prepared this chart, and this chart is taken from the textbook. The firstly, discharge. Discharge in bacterial conjunctivitis may be purulent or mucopurulent. In viral conjunctivitis, discharge is mainly watery in type. Chlamydial conjunctivitis, mucopurulent type of discharge is present, and in allergic conjunctivitis, ropey or watery discharge may be present. So, if in the question ropey discharge is mentioned, then it have to be allergic conjunctivitis, not any other type. Now, papillae. It is absent in case of viral conjunctivitis and always present in allergic conjunctivitis. Follicle. Absent in bacterial conjunctivitis, present in viral and chlamydial conjunctivitis. Pseudomembrane may be present in case of bacterial and viral conjunctivitis, but it has to be absent in chlamydial and allergic conjunctivitis. Now, pannus. Pannus can only be present in chlamydial conjunctivitis and in special, that is vernal allergic type of conjunctivitis. Now cytological feature, in bacterial conjunctivitis, neutrophil and microorganism is demonstrated. In case of viral conjunctivitis, early stage neutrophil must be present, and in late phase lymphocytes and multinuclear cells should be present. In case of granulomatous conjunctivitis, neutrophil, lymphocyte and plasma cell is present. And in case of allergic conjunctivitis, eosinophil is present. As it is a hypersensitivity reaction, so eosinophil has to be present. Now, type of inclusion bodies. Cytoplasmic inclusion body is present in case of viral conjunctivitis due to pox, and nuclear inclusion body is present in case of viral conjunctivitis due to herpes. Now let us classify the bacterial conjunctivitis. It can be classified into 4 categories: acute, hyperacute or acute purulent, chronic and angular. The first 3 is on the basis of time of occurrence. Acute, it can show mucopurulent discharge, membranous like membrane formation, or pseudomembranous like pseudomembrane formation. Now what is the difference between membrane and pseudomembrane? If we remove a membrane, it will bleed, but if we remove an pseudomembrane, it won't bleed. Now I have taken the images from the book. These images can come in OSPI, so we have to know the images by heart. Mucopurulent bacterial conjunctivitis is mainly due to Staphylococcus aureus. The causative organism in membranous bacterial conjunctivitis is mainly in adults it is pneumococcus, and if it is unimmunized child, then it is due to diphtheria. As we know that immunization includes DPT vaccine. If the child has not taken the DPT vaccine, then he or she is prone to diphtheria. Now the hyperacute or acute purulent conjunctivitis, it is due to Neisseria gonorrhoeae, and in treatment we use intramuscular ceftriaxone 1 gram single dose, followed by erythromycin continued for 2 weeks. Now if we see the angular conjunctivitis, it is due to Moraxella lacunata or Oxenfield. Treatment include oxytetracycline and zinc lotion. Next is viral conjunctivitis. Viral conjunctivitis is dependent classified on the basis of etiology. That is, it can be due to adenovirus, or it can be due to herpes simplex virus, herpes zoster virus, or molluscum contagiosum. Now adenovirus can produce various types of symptoms. Depending on that, they further classified into non-specific follicular conjunctivitis, epidemic keratoconjunctivitis, and pharyngoconjunctival fever. Now I have attached the image. In follicular conjunctivitis, we can see in the conjunctiva red follicles. Now epidemic keratoconjunctivitis can again be of several types. It can be superficial punctate keratitis, or pseudomembrane and petechial hemorrhage may be present. Now molluscum contagiosum, what is that? In that case, unilateral painless nodules are formed and umbilicated appearance is seen. Now chlamydial conjunctivitis. Chlamydia can be of several types, but we are more interested in trachoma, which is caused by Chlamydia trachomatis. It is type 4 hypersensitivity reaction. What are the clinical features? One is sago-grain follicles. One is cicatricial sign, that is scar formation. Arthur's line, Habert's follicle. It is the pathognomic of trachoma. What is Habert's pit? Whenever the follicles formed at the limbus are healed, some depressed regions are formed. These are known as Habert's pit. Now pannus. Pannus can also be seen in case of trachoma. Now what can be the complications? Trichiasis. which ultimately leads to corneal ulcer. That means whenever the eyelashes are bent inward, it can injure the cornea and ultimately leads to formation of corneal ulcer. That will lead to scar formation, ultimately can lead to loss of vision. Now, treatment. Safe strategy is followed. What is safe strategy? S for surgery. It can be done for trichiasis and entropion correction. Antibiotics. It can be topical or systemic. In case of topical antibiotic, 1% tetracycline or 1% erythromycin eye ointment can be used 4 times a day for 6 weeks. If systematic is applied, then tetracycline or erythromycin 250 mg oral 4 times a day 3 to 4 weeks can be applied. Now, facial cleanliness and hygiene. Cleanliness is that frequent face washing. What is hygiene? We won't use a towel of another person. We won't share handkerchief with others, like that. And what are the environmental changes? These are control of flies or fomites, which ultimately leads to transmission of trachoma, that is chlamydial trachomatis. Now we follow Fisto classification, and depending on that we mention the treatment strategy. F for TF, that is trachomatous inflammation follicular. F for follicular. I for TI, that is trachomatous inflammation intense. TS, trachomatous scarring. TT, trachomatous trichiasis. CO, corneal opacity. Now in first two cases, that is TF and TI, we apply antibiotic. But in TS, that is trachomatous scarring, as there is only scar formation, there is no pathogenesis or infection, no treatment is needed. And in case of trachomatous trichiasis, for the correction of trichiasis, we need surgery. Now I have added the images of all the 4 stages. The images above showing trachomatous inflammation follicular, we see white follicles in the upper palpebral conjunctiva. In the second image, we see pannus formation. The left one is progressive pannus. Here we can see the left one is progressive pannus and the right one is regressive pannus, and this is the clinical picture. The third one, that is TI, it is trachomatous inflammation intense. The downward and second most from the left is TS, that is trachomatous scarring. Right to that is trachomatous trichiasis, where we can see that the eyelashes are bent inwards. And ultimately the last one is corneal opacity, which shows the opacification in the cornea. Now we have discussed the chlamydial conjunctivitis. Next come to allergic conjunctivitis. Allergic conjunctivitis can be of several types. First one is simplex allergic conjunctivitis. It can be seasonal, perennial or hay fever. Vernal conjunctivitis, it is the most important type. In this we see papillary hypertrophy, cobblestone appearance, then Horner's Tranter sign. What is that? I have attached this picture on the right side. That is in the limbus we see white spots. Pseudogerontoxin can be seen. It is white grayish opacity in the peripheral cornea, similar to Arca senilis. And shield ulcer can be seen. The image is at the right. Denny Morgan line can be seen. It is horizontal creases or folds that appear beneath the lower eyelid. Maxwellon's sign, that is ropey discharge, can be present. Now for treatment, cold compression can be done, topical antihistaminics. As it is an allergic reaction, we apply antihistaminics, mast cell stabilizer. The drug of choice is olapatadine or alkafladine. Now topical steroid can be used for symptomatic relief. In atopic keratoconjunctivitis, Hartog sign can be seen, that is lateral eyebrow lash is lost here. Giant papillary conjunctivitis, flictenular keratoconjunctivitis. Now the name suggests flicten. What is that? It is nodule near the limbus. Now nodule can be of two types, Koppe's nodule and Busaka nodule. Koppe's nodule is present at the pupillary margin and Busaka nodule is present at the surface of the iris. Now it can also be of contact dermoconjunctivitis. Now we have completed the conjunctivitis. In next session I will discuss with the next disease. Thank you. Please like, share and subscribe my channel, and notes of this lecture I will attach in the description box in the form of Telegram link.